Good evening and welcome to Doctors on Call. I'm Dr. Peter Nalin, Professor and Head of the Department of Family Medicine and Biobehavioral Health and Associate Dean for Rural Medicine at the University of Minnesota Medical School, Duluth campus. I'm your host for our program tonight on lower extremity, knee, foot, and hip problems. The success of this program depends on our viewers, so please call with your questions or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Billy Haug, a physician who is board certified in family medicine and sports medicine, practicing emergency medicine at the Cloquet Memorial Hospital. Dr. Kristi Hultman, an orthopedic surgeon with Orthopedic Associates of Duluth, and Dr. Luke Widstrom, an orthopedic surgeon with Essentia Health Orthopedics and Sports Medicine. Our medical students answering the phones tonight are Hank Larson from Spring Valley, Wisconsin, Joe Miller of St. Michael, Minnesota, and Connor Mikolajczyk from Red Wing, Minnesota. And now on to tonight's program on lower extremity, knee, foot, and hip problems. And Dr. Widstrom, already the first question is for you. How might a patient better prepare their individual health prior to surgery?
Sure, that's a good question and something we get in clinic quite a bit. A lot of patients that we're seeing are going in for joint replacement eventually, and so optimizing some health factors there can make a big difference. So patients that have diabetes, getting the blood sugar under good control is very important. It can really help with healing if patients can get off of nicotine products, avoid smoking. If we know that they're going to have surgery down the road, working on weight loss ahead of time can make a big difference, especially in recovering from a hip or knee replacement. And then in the days leading up to surgery, making sure that patients are getting good sleep, getting plenty of rest, hydrating well. Those are kind of the key factors.
Thank you. And Dr. Hultman, there's certainly been much attention regarding the injury to professional Aaron Rodgers and his Achilles tendon. What can we anticipate about his return, or what would a patient anticipate for the time to return after an Achilles tendon repair?
Okay, so after the repair of an Achilles tendon, typically the earliest return to sport is going to be around 6 months. And the reason for that is when we repair that tendon, we're bringing the ends back together. However, the tendon still needs time to heal and remodel into a nice functioning tendon. And then once you start the rehabilitation, you're really retraining your brain and the muscle and tendon so that everything's working together as a functional unit. Now, when we see professional athletes like Aaron Rodgers having this type of injury, we have to remember that he's a professional athlete. He's in prime condition, and he has a whole team that's rehabbing him and getting him back to sports. And he also has some other motivations where for our typical patient, we want you to have that best outcome, and we want to really decrease that risk of re-tearing. So we may take a little bit more cautious approach in terms of getting you back.
Thank you for that. And Dr. Haug, for a 55-year-old patient with knee pain for about a year on daily walks and somewhat worse on the trails or with squatting, what might be the cause and what could be done to help with this discomfort?
Yes. Well, as we move through life, our cartilage pads can start to wear a little bit thinner than normal, and they can cause some symptoms such as swelling or locking or discomfort. If you think about the cartilage pads themselves, they're called the meniscus. There's a meniscus on the inside part of your knee and on the outside part of your knee. And you can think of them as little shock absorbers or like little rubber donuts almost. And as they start to wear down, they can tear. And as we get into our 30s and 50s, we see more of this than we do earlier in life. On an MRI, you can see in this picture that there's a signal in that little red circle, and that is a tear in that cartilage pad called the meniscus. And that can cause discomfort with walking or squatting, or like the patient is asking about on trails. These kinks can be treated by strengthening the quadricep muscles, cortisone injections, and then there are other mechanisms of treating these tears as well.
Thank you. Dr. Widstrom, what are signs and symptoms of an infected joint that would lead a patient to seek care?
Sure. So there can be some symptoms in the joint itself, and then there can be some more systemic symptoms. So in the infected joint itself, typically you're going to see swelling. The joint can be very painful. It will feel warm to touch, may even feel hot. Typically there's going to be pain with even gentle range of motion in the joint. And then if someone is suffering from an infected joint, they may feel systemic symptoms such as fevers, chills, may have some general aches, almost flu-like symptoms. That does not always come on right away, but typically you will see those, the swelling in the joint is one of the big ones. So,
thank you. And Dr. Hultman, the meniscal tear, does the patient definitely need surgery, or how do you determine that?
So with meniscus tears, there's several types of tears. So the one we commonly think of is the traumatic tear. It happens, when we're doing sports activities or we have a trauma or injury, and that tends to be a more acute tear in a younger patient. Those ones are typically repaired. In a young patient, we really want to preserve that meniscus. Now, as we were talking about earlier, as we get older and we get more wear in our knee, as we beat up that cartilage and that meniscus cushion, we get some tears in there. Those tears tend to be more degenerative, more wear and tear type tears. And on those, a lot of times we can treat them conservatively with injections and strengthening the leg and other conservative type measures. But occasionally we try those and we continue to have symptoms. And those ones we can go in and either repair or trim some of those kind of hangnail tears to the meniscus out to relieve the mechanical symptoms. But that does remove some of the meniscus, which certainly is kind of helping lead to some arthritis. So that's why we try that non-operative tear or non-operative treatment in the degenerative type tears.
Thank you, Dr. Hultman. And just following up, you mentioned that little bit of removal. Mm-hmm. Do you notice that on follow-up imaging, that removal?
So if we did an MRI after surgery, we can certainly see in there parts of the meniscus where we've trimmed it so the meniscus will not have that smooth, normal contour after some of it has been removed.
Thank you. Dr. Haug, what about the healing of plantar fasciitis at the heel, and about how long does that take?
Plantar fasciitis can be a very painful process for people who are working on hard floors, such as concrete floors, spending a lot of the time on their feet during their work days. Ways to go about treating plantar fasciitis and time frame kind of depends on the person. One of the ways of going about it will be to wear softer soles, or a heel cushion is one way of doing it. The other can be wearing a walking boot that can really shut the heel down and really give it a rest. Typically what I counsel patients is about every 3 to 6 weeks you'll notice some improvement. Normally it's not 3 to 6 days, but if you think a little bit further down the road, I think that's when things will start to come around.
That's encouraging.
Yes.
Dr. Widstrom, an individual has stepped in a pothole, twisted their knee, and the posterior knee is now swollen and painful, unable to move the knee much at all. What could that injury be?
It could be a few different things. So a twisting injury of the knee, you certainly worry about a meniscus tear, an acute meniscus tear. That can cause acute onset pain. It can cause limited range of motion and swelling. With posterior swelling, you would also think about the possibility of a Baker's cyst, also known as a popliteal cyst. And so that's swelling in the back of the joint that's coming from basically too much fluid in the joint itself, and it gets pushed to the back. And so if arthritis is exacerbated, that can cause excessive joint swelling that can get pushed into the back of the knee and present that way. And if the knee feels swollen, it can make it feel tight, and it can reduce range of motion. And then another thing to think about, anytime there's any sort of an acute injury, twisting mechanism, or trauma to the joint, you always want to be conscientious of the possibility of a fracture too, and that could present that way as well. So coming in and getting some imaging, starting with an x-ray, is certainly important in a setting like that.
Thank you. And Dr. Hultman, a viewer asked from Duluth, are there new types of knee prosthetics?
So we've made a lot of progress, I would say, in the last decade of ways to treat arthritis and cartilage injuries within the knee. So the main prosthetic that we see is the metal components, where there's essentially a metal cap on the end of your thigh bone and a metal tray on the top of your shin bone with a plastic piece in between that lets them glide. Now, the equipment and device makers are constantly upgrading what things are made out of, how long our plastic lasts, and things like that. But other things that we've been working on are ways to restore the cartilage. So some of the surgeries we have available are things like the Macy procedure, where we grow out your cartilage cells and we actually put a cartilage patch in that cartilage pothole that you have within your joint. Another procedure we have is called an osteochondral allograft, where we take cadaver cartilage and bone and we basically make a little socket where you've got that divot and put a new bone cartilage plug in there. Now, as we get older and our arthritis gets worse, we typically end up with that knee replacement with the metal and plastic that's in there, but certainly in our younger and more active patients, we've been progressing more towards the biologic options as well.
Do your patients ask you about how their body responds to the cadaver graft?
So typically the cadaver graft will go through multiple tests to make sure that there's no infection or other materials or bacteria in there, and then we do wash it and process it before we go in, and then we do give it a bath in PRP or the patient's own whole blood before we insert it. So most people tolerate it very well, and having a reaction with the kind of the donor tissue is usually not a problem with those grafts.
Thank you for explaining that. Dr. Widstrom, what are impacts or changes on the knees, ankles, and feet as a result of obesity?
Yeah, good question. So obesity increases loading through the weight-bearing joints. And so this can, over time, accelerate cartilage wear compared to someone that's at a normal weight range. So even with walking, there's going to be increased force through that joint and increased stress through the cartilage. So essentially the cartilage can wear down faster.
Thank you. Dr. Hultman, what are some of the influences on the duration of a hip replacement's longevity in a patient?
Okay, so the hip replacement is one of the best orthopedic surgeries that we have. Patients do very well with this. And the current kind of main thing that determines how long it lasts is really lifestyle and patients' body habitus. So in our older patients that are mainly walking around their houses, walking around the neighborhood, the hip lasts a long time. In our younger patients that are doing more high impact things, you're putting a bit more stress on the implants and you can get a bit more wear. Now, we've had great improvements with the components that we put in the hip. We use different materials such as metal and ceramics and plastics, and I would say the modern hip implant is lasting at least 20, 30 years in a majority of our patients.
Oh, that's tremendous.
Yeah.
Dr. Haug, a patient asks how long it will take for a pulled quadriceps muscle to feel not as painful, so when they're using their leg.
Well, that's a good question. The quadriceps is a large muscle group that's very powerful, and so typically we think about large muscle groups taking quite a bit longer to heal or settle down than smaller muscle groups. With a quadricep tendonitis, depending on the severity, you can expect to be out about a month, depending on the age of the patient. It always seems like younger folks will bounce back more quickly than we think, but typically what I would say is about 4 to 6 weeks for an injury like a quad tendonitis.
Thank you. Dr. Hultman, a caller asks, how common are blood clots after knee surgery?
So definitely having a big surgery like a knee replacement is a big shock to the body. The body doesn't know the difference between surgery and trauma. So its kind of reaction and clotting factors do increase within the bloodstream. The risk of a blood clot is fairly low. However, after a big surgery like a knee replacement, we typically will place the patient on aspirin or other blood thinners to minimize that risk. With knee surgeries like a scope or an ACL, it's a smaller surgery, the risk is lower, and certainly the more the patient is able to get up and move around is going to lower that risk of blood clots.
Thank you. Dr. Widstrom, a viewer from Superior, asks, can a back problem cause knee pain and vice versa?
Yeah, that is certainly a possibility. Knee pain can certainly alter someone's gait, and walking with an affected gait can cause increased stress through the low back, especially someone that has prior existing back issues such as arthritis or disc bulging. Back pain can cause knee pain. Typically, if it's going to cause pain in the lower leg, though, it will radiate down and it won't be isolated to just the knee. Not saying that can't happen, but that would be a less common presentation. Usually you'd see the pain radiating down the leg, sometimes with lower leg weakness, sometimes with numbness.
Thank you. Dr. Haug, earlier we heard about the Baker's cyst, and a viewer asks, how long does it take to heal?
Baker's cysts are swelling behind the knee that can kind of come and go normally and naturally. Sometimes they can be tiny, so tiny that you can only see it on imaging, and other times they can be about as big as a softball. When you think about the body's time to resorb that fluid, it can be a really long time sometimes before it will completely kind of disappear over a period of months. Other times they can actually pop on their own and cause a lot of discomfort behind the knee and into the calf, so much that it can fool doctors into thinking that it's a deep venous thrombosis or a blood clot. But typically it can take several weeks for those to abate.
Thank you. Dr. Hultman, from a viewer who's already had a hip replacement 2 years ago on the left foot turns a bit white after showering. Could Raynaud's worsen as a result of surgery, and any suggestions about evaluation?
I mean, certainly, Raynaud's does have that reaction and is associated with the nerves in the area. And anytime you have a surgery, certainly it can alter kind of what your baseline status is. If you're noticing that, it's happening more frequent or symptoms are changing, then, it's certainly something that is worth having looked at.
Especially for what might be going on,
Yep.
both with nerves and vasculature,
vascular,
potentially. Yep. Okay. Doctor, does the SI joint move like other joints?
There's a little bit of mobility to the SI joint, but it's not a very highly mobile joint. So, and as that joint, in time, some people will develop arthritis in that joint, and it can stiffen, and increased stress through that joint can cause pain if it's the little motion that it does have is restricted.
And Dr. Haug, what are some common injuries to the muscles gluteus maximus and medius?
There are overuse injuries associated with those largely that can cause the hip to hurt. And so typically when you're working somebody up for hip pain, you will think about those muscle groups. Those muscle groups are commonly ignored when it comes to training programs because typically athletes and people will focus on the larger muscle groups. Even though we use our gluteus, medius, and maximus every day for activities of daily living, we don't often specifically train those body parts. So it can be a little bit complicated as to kind of what the etiology of the pain is when we're talking about muscles like that.
Thank you. Dr. Hultman, about preparing for surgery in the operating room, how does the team ensure that the surgery will be done on the correct side?
Okay, so always a big concern when you're going in for surgery. So typically when you go in for surgery, like say you're having a knee replacement, the doctor is going to meet with you in the pre-op area, and at that point they're going to go over what the procedure is that we're doing, what side we're doing it on, and then they'll have a marking pen, kind of looks like a little Sharpie, and they're going to put a mark right in that area of the surgery on the correct extremity, and they're going to check with you. So I'll typically ask my patient, what are we doing today, and what leg are we doing on it, or it on, and can you point to where we're going to do this? And then we mark it. And then when nursing comes in, they're going to check the procedure with you again. When anesthesia comes in, they'll check the procedure. If you're getting any sort of block or numbing injection prior to surgery, the anesthesia team will also mark that side of the leg. And then when you get into the operating room, before we start the procedure and before we do anything, everybody in the OR room is going to go through and say their parts of the surgery. So who is the patient? What are we doing? What side are we doing it on? Have we given antibiotics? All of these things. So there's lots of checks that have been put in place to make sure that the procedure is correct, the patient's correct, and the site is correct.
Thank you for that. Very reassuring. Regarding a patient with foot numbness, age 67, and not diabetic, what, Dr. Haug, might be some potential causes?
And not diabetic?
Not diabetic, yet foot numbness.
That is a peripheral neuropathy, and so there can be different reasons why people will have a peripheral neuropathy. One is from a low back problem, like a bulging disc. Typically, we will see a lack of sensation or pain in a foot or in the extremity, and we will see evidence of that sometimes with a diminished reflex in the ankle. Other times, there can be chronic diseases or even acute things that can cause there to be numbness in the foot. But typically, what we'll think about when we hear that will be to ask about underlying back problems or disc bulging problems or arthritis in the low back as well.
Dr. Widstrom, briefly, what are some considerations for the right medication choices safely for arthritis pain in a patient in their 80s?
Oh, sure. So the main categories of medications that we're using for arthritis would be non-steroidal anti-inflammatories, so medications like ibuprofen or naproxen. And then the other main category would be acetaminophen. And so when you're talking about the non-steroidal drugs like ibuprofen, you want to make sure that patients have good kidney function. So they should have their kidney function checked and ensure that that's working properly before recommending that. And then the other thing is making sure that they don't have any history of GI discomfort, so stomach discomfort, reflux, ulcers. There are some other considerations depending on what other medications they're taking. If someone is on a blood thinner like warfarin, they probably don't want to be on a non-steroidal anti-inflammatory because that can also thin the blood. So looking at a patient's medication list is important before making recommendations like that. With Tylenol or acetaminophen, probably the biggest factor is liver function, as that medication is processed through the liver.
And this is a brief question before we wrap up, Dr. Haug. How long can a patient get occasional cortisone shots? Just briefly. Yeah.
Typically what we would think about is a couple of times a year, maybe a little bit more frequently than that, but typically we try not to overdo cortisone shots.
Yes, thank you. Well, I want to thank our panelists, Dr. Billy Haug, Dr. Kristi Hultman, and Dr. Luke Widstrom, and our medical student volunteers, Hank Larson, Joe Miller, and Connor Mikolajczyk. Please join Dina Claiborne next week for a program on grief and loss when our guests will be Dr. Deb Semmelroth, Coral Popowitz, and Bridget Benson. Thank you for watching. Good night.